I am Dr. Sharjeen and you are watching my YouTube channel. If you like my videos, don't forget to subscribe my channel. Now, if you remember the last ophthalmic sign I posted was 217 and it was a very important sign. But it was a bit difficult to get it it looks a straightforward case of striate keratopathy. There are large um, hexagonal spaces in the center of the cornea, but there is a clue, there is a hint that there is a sharp demarcation line between the clear cornea and the edematous cornea. So that gives you a clue towards the diagnosis. So I thought I should discuss this important sign in detail. This is a video of a 60 years old male patient who was referred to me after 8 days of treatment. The patient underwent cataract surgery, phacoemulsification with the foldable IOL implant, and at the conclusion of the surgery, the surgeon noted that the cornea becomes hazy and there is a thin, linear, transparent, curvy membrane that was suddenly stripped on the inside of the cornea. So yeah, it is a case of Descemet's membrane detachment. Now, coincidentally, few weeks back, we discussed this complication. I was accompanied by two seasoned ophthalmologists of my area with 30 years experience in ophthalmology. I've got 10 years experience, and one of them shared his experience that he had seen two cases of complete extensive Descemet membrane detachments in his entire career of 30 years, and one recovered and other went into bullous keratopathy. And the other ophthalmologist told that he has experienced a lot recently, and he then asked us and we discussed. When I was asked, I told them that thanks God I have not experienced a complete Descemet detachment yet, but I encounter small detachments in routine that occur at phaco main incision port. That stripped Descemet's membrane typically seen near the incisions like a flap, loosely adherent, floating in the anterior chamber with the rolled up edges and moves vigorously while irrigating the anterior chamber. So, on slit lamp examination, Descemet's membrane is diagnosed as a clear optical space between stroma and Descemet's membrane. As it is a transparent membrane, it is treated first by injecting a blue dye, trypan blue dye, into the anterior chamber to stain it so it becomes visible. Then first it is if it is folded, then it is unfolded, and then intracameral tamponade with air bubble or non-expansile concentrations of SF6 or C3F8 is injected to oppose the Descemet membrane to corneal stroma. In past, Descemet's detachment was mostly seen as a cataract surgery complications, especially while performing hydration of ports when you push gush of fluid into the inferior stroma near the Descemet's membrane, or when we perform wound construction with blunt phaco knives, or when we create a tight wounds and insert phaco probe that rub against the Descemets and detaches it, or implant IOLs through these tight wounds. With the advent of corneal procedures like DMEC and DSEC, the importance of Descemet membrane has increased manifold, and the knowledge about the Descemet membrane has increased. So here now I will discuss the classification of the Descemet membrane detachment that is proposed by Susan Jacob, and I have also taken this classification from Amar Agarwal and Susan Jacob, so I'm thankful to them, and I give credit to the below mentioned discussion that Susan Jacob has given resemblance with RD classification. Like Descemet's membrane detachment, you can classify it just like retinal detachment. Descemet membrane detachment can be classified as rigmatogenous due to tear of the Descemet membrane or hole in the Descemet membrane, tractional, or bullous exudative. So rigmatogenous Descemet membrane detachment usually occur as an intraoperative event in the cataract surgery, which is discussed above, when there is a break in the Descemet membrane with fluid accumulation between the Descemet membrane and overlying stroma. Now that is called a tear in the Descemet membrane. The other is the hole in the Descemet membrane that can also cause rigmatogenous Descemet membrane detachment, and that occurs as a hole as a double anterior chamber is formed during DELC surgery, and rigmatogenous can also occur during trabeculotomy, trabeculectomy, AC maintainer insertion, and DMAC procedures. Tractional Descemet membrane detachment occur secondary to inflammation or fibrotic process, incarceration of Descemet membrane in an inflammatory process, for example in peripheral anterior synex, or incarceration of Descemet in wound or suture with subsequent contraction. So you have to relieve that contraction as well, and then give intracameral tamponade in tractional Descemet membrane detachment. Bullous Descemet detachment occur due to posterior corneal abscess, when the pus accumulates between Descemets and stroma, tumor cells accumulate between Descemets and stroma, infection or inflammation. So space between stroma and Descemet membrane is filled with pus, exudate, fluid, viscoelastic air depending upon the cause. This configuration is also seen as a part of Anwar's big bubble technique in DELC, or when you accidentally put viscoelastic in the space between Descemets and stroma. So what happens when Descemet detachment occur? There is overlying epithelium and stromal edema, loss of transparency of the cornea, striate keratopathy, as you can see here, pain, watering, decrease of vision. On anterior segment OCT, the tractional Descemet membrane detachment is straight, while rigmatogenous is folded, scrolled, crumbled, undulating, linear. Treatment for clinically insignificant, smaller asymptomatic Descemet membranes, which we see quite often, is not required, but care should be taken if it occurs at the start of the phaco surgery by not extending it further to become significant. So how to prevent the extension of a small insignificant? Use new sharp phaco knives, enlarge the wound, enter the probe or IOL with AC fully filled with viscoelastic, and by pressing down the lip of the wound to avoid rubbing against the peeled Descemet membrane. Significant Descemet membrane detachments are dealt with 14% C3F8 or 12% SF6 intracameral, or fill the anterior chamber with air. Give topical 1 hourly of hypertonic drops, cycloplegics, antibiotics, steroid ointments for 2 to 3 weeks. corneal edema usually resolves within 2 to 3 weeks when the Descemet membranes attaches, but if it continues beyond that period, it means that you have to perform endothelial keratoplasty if it is visually significant and symptomatic. So that was a detailed discussion about one of the important and rare complication of phacoemulsification, Descemet membrane detachment, and I hope you would have learnt a lot. Thank you very much.